হাফিজ ভাই, আসসালামু আলাইকুম।
তুষার ভাই জাস্ট এখন থেকে 10 সেকেন্ড পরে কথা বলা শুরু করবেন, তাহলে জাস্ট আফটার 10
Okay.
সেকেন্ড ইউ ক্যান স্টার্ট ইউর টক।
তুষার, আতার ভাই কথা বলো। আতার ভাই
জি স্যার,
মাইক।
আমরা শুরু করে তারপরে ইয়ে করবো। Should we start?
Yes, you can start.
Assalamu alaikum and good evening, everybody. Welcome you all in today's webinar on ECG Basic and Beyond, organized by ECG Study Group. Today is our 39th lecture, and the topic is Art of Interpretation, and our speaker is our most loved one, Professor Abdul Wadud Chowdhury. But before starting the program, I'd like to announce we have an announcement that mother of our respected Professor Atahar Ali sir is very much sick with COVID-19. We all pray for her early recovery, and I hope she will come down soon. So I request Professor Abdul Jamil sir to say a few words regarding Professor Abdul Chowdhury sir, and then we should proceed for the presentation. Jamil sir.
Thank you, Tushar, for inviting me to say something about Professor Abdul Wadud Chowdhury. I met him long ago while we were in the first part in the FCPS, and we crossed the first part barrier together. In that session, we passed 14 altogether, and among them, two guys were passed only for first attempt, that is Abdul Wadud Chowdhury and Saifuddin Akram. From then onwards, I know him, and we worked all together in Dhaka Medical College. I was assistant registrar first in CCO, and then in the ward number 22. And he worked under Professor Naseeruddin Ahmed. And from that, there we had many academic sessions together in discussion, and he passed FCPS Part 2 in first attempt also. I took a lot of attempts. While I was struggling for passing FCPS Part 2, Wadud helped me and my partner, Dr. Professor Bilal Alam, and he used to show us short cases and long cases 2 days in a week, and his teaching was excellent and helped me a lot to pass the FCPS Part 2. And every undergraduate student who are taught by him, they know him very well, how academic and how good he is in his respective subject. Later, he passed did MD Cardiology from NICVD under Dhaka University. And now what is Professor Abdul Wadud? He is always academic. He is always want to teach his fellows nicely. That's all about him. And he one thing to mention, he was the first boy of Dhaka University in MBBS undergraduate when he passed MBBS, and later did two highest degree of Bangladesh he achieved. Now he is working as Professor of Cardiology in Dhaka Medical College. That's all about I know about him. Please go ahead.
Wadud sir.
Yes.
Sir.
Let me share there. Jamil bhai, I'm really grateful for your kind words, but you were saying too much about me. Actually, I love teaching. I love enjoying what I know with others. That's the thing. Today, the topic is the art of ECG interpretation. Why art? Because ECG is a funny thing. Seeing one ECG, one can find out only a part of its information, and they can find out a lot of information from it. You have to know how to extract the story from ECG, and therein lies the art. And so, let us go into the topic. Heart is an electrical organ, and ECG is nothing but the graphical presentation of summation of electrical activity of the heart as a whole. Is very non-invasive, inexpensive, simple, and reproducible. But remember, ECG diagnoses are valid only if the electrodes are placed in correct anatomical location. Lead wires are attached to appropriate electrodes, and recording is of good technical quality. And of course, the interpretation should be logical. Just the usual picture, PQRST, and the history of ECG has been well illustrated by the previous lecture, our teacher, Professor Nuzli Samsar. That was beautiful oration by him. We know we talk about lead. The term lead refers to the placement of electrodes in relationship to the heart. But what I think of it? I think of it is a lead like an electrical window through which I am looking at a particular side of the heart. That's the usual position where we put the leads. V1, V2 in the fourth intercostal space near the sternal margin, right and left. V4 just below the nipple in the midclavicular line. V in the fifth intercostal space. V3 in between. V5 in the same line of V4 in anterior axillary line. V6 in the same line in mid axillary line. And that's the right-sided and posterior chest leads. Remember that the posterior chest leads 7, 8, 9 are put in the same line of V4, 5, 6. Posterior axillary line, the mid-scapular line, paraspinal line. And that's the way we talk about lead 1, 2, 3, AVR. We know about this. Now let's start interpreting an ECG. How do I do that? Follow a game plan. Be systematic. What I do, I try to diagnose anomalies of different components of the ECG graphs separately, then try to reach a logical conclusion. If I could reach a diagnosis, even then, the description of anomalies will still help. So let us be brave together. If you want to be systematic, look at the standardization. Look at the measurements, the rhythm, the conduction, the waveform description, and then proceed to ECG interpretation. And of course, sometimes comparison of the previous ECG is very helpful. But first and foremost, before I start interpreting, I should screen the ECG for quality. Verify the patient's name, registration ID, and date and time. Is it really the patient's ECG? Always look at the name and age. Is it really the current ECG? Look at the date and time. There are many occasions I remember in CCU, in the hurried atmosphere of CCU, where there were only 12 beds in NICVD at that time when I was a student there. But there are always patients in the floor too, even in the CCU. And sometimes the ECG get mixed up. So it is always important that we look at the name and date and age. Sometimes same name people can be there too. So always look at the name and age. And perhaps sometimes it's important, are you looking at the current ECG or the older ECG? That's also important. And the timing, because if there is any new changes, how can you be sure it's the new change or it was present before? Look at the time. And in case of acute setting, it's important that the timing should be there in the ECG. Look at this one, the importance of time, well manifested. Here, the ST is well elevated in anterior leads, V1 to V6. So this is an acute ST elevated anterior MI. The patient is very much ready for revascularization, either by primary PCI or by thrombolysis. Look at this one. The patient has well-developed Q wave. So there is some ST elevation still present, but the Q wave is there, and there is also right bundle branch block. The time has advanced some time. Same patient, Abdul high. So this patient, if you even thrombolize, the chances of successful thrombolysis may not be that much. Make sure that the voltage is 10 millimeter per millivolt and well calibrated. That's the way we look at the ECG, and that's the calibration we find. Now look at this one. Here standardization was done at 1 millivolt equal to 10 millimeter deflection. Now look at this one. Same patient, but the standardization is now 20 millimeter. There are big complexes. Now look at this one. Same patient, the standardization is only 2.5 millimeter, 1/4. And what happens? There seems to be bradycardia with very small ECG. I have made a ECG of a hypothyroid patient who have pericardial effusion, which is actually not there. This is an example of the same thing. This is the normal ECG with a rapid rate of a patient, 10 millimeter deflection, sinus tachycardia is present. The same patient with 5 millimeter deflection looked like sinus tachycardia with small complexes. That means this can be a case of pericardial effusion with due to other causes, not due to hypothyroidism. So sinus tachycardia is there with the small complexes. Now look at this one, 20 millimeter deflection. The complexes are big. Do the patient have any LVH or something like chamber enlargement? Is there P pulmonally? Look at lead 2. The P was very sharp and pointed and big. No, that patient doesn't have that. I have made it by my technical error of doing it at 20 millimeter deflection. Sometimes when the P waves are not well seen, we make that out to make out the configuration of the P wave, whether it is present or not, how what is the morphology of the P wave. We make it 20 millimeter deflection. But if we do it by error and interpret it likewise, we'll be in grave error sometimes. And in many ECGs, in the same ECG, computer generated ECG, so look at the boxed markers. The upper part, normal 10 millimeter deflection calibration, but the lower part, it has made the 5 millimeter calibration. So if you think that there is loss of R wave in V5, V6, you'll be wrong, because there is actually half voltage calibration. Now, what about the timing? ECG paper speed is 25 millimeter per second, and each small square equal to 1 millimeter, which in time sense is equal to 0.04 second. One large square, 5 millimeter, is 0.2 second. 5 large square is 1 second. What is the effect of speed on ECG? The example is here. This is the usual speed. The recording shows a beautiful normal complexes. Now this one, very narrow complexes and the very rapid rate. Actually, the speed is 50 millimeter per second. So the complexes has become narrow. This is often is done in the CC or IC. You will find out in the monitor. There is often, it seems to be there is a tachycardia, but look at the heart rate. The heart rate is 60 or 70. That means the speed is very high. What about if I reduce the speed? The complexes will be wider and I will induce an apparent bradycardia. That's a paper speed of 10 millimeter per second. And by this, we can make sometimes a complex quite bigger. So we have to look at the speed to decide about the width of the Qrs complex. That's the timing is very important. Now look at the other quality, correct lead placement and noise. Inaccurate lead placement is unfortunately not very uncommon. that can be inaccurate limb lead placement, that can be inaccurate chest lead placement. Now, limb lead placement inaccuracy is quite common. Right arm, left arm lead transposition is virtually, you can find in every country of the world. P wave in lead 1 and 2 should always be positive in a sinus rhythm. P wave in lead FER should be negative. When a right arm, left arm transposition occurs, P wave becomes negative in lead 1. QRS also become negative. The reverse occurs in lead FER. We find a positive P, positive QRS in lead FER. Look at this one. The P wave is inverted and the Qrs complex also inverted. The P wave in FER is positive. What about this one? The same thing has happened. If we correct it, we'll find out that actually there is RF loss in case of 1 and FEL. No, that's not true. It's actually we have done the armlet reversal. What about MI situation and other lead quagmire? For example, if a left arm and left leg is reversed, what will happen? This is the case of acute ST elevated inferolateral MI. The ST segment is elevated in lead 2, lead 3, AVF, also in V5, V6. There's inferolateral wall acute in ST elevation MI. There's also ST depression in anterior lead, suggesting there could be posterior extension. But this patient has that left arm, left leg change. And what happens? The MI has now become ST elevation in 1 FEL, 5, 6. So that's anterolateral MI. Which one is true? Which one artery is the culprit vessel? We have to look at the ECG properly if we have any confusion and redo it properly so that we can reach a diagnosis. What about inaccurate chest lead placement? That's the usual position we know. We have talked about it. But look at this one. The patient is obviously a post-surgical patient, obviously in a ICU setting, but how the technician has placed the leads? Is it in the fourth intercostal space, V1, V2? Of course not. What about V3? Way down, it should be between the V4 and 2. What is the location of the other leads? Very inaccurate. That's the proper positioning. The before and after correction. Look at this one. The technician is very generous. He has placed the leads very generously all over the place. The patient is intubated. So this is an ICU setting. And even there, if they made that mistake, the ECG interpretation, as we are doing, will be wrong. That's the proper positioning. Why this is important? Because if you put the leads in V3, V1 and V2 in third intercostal space, one space above the usual position, there will be loss of around 1 to 2 millimeter of R wave in the V1, V2. So already the R wave in V1, V2 is small. If you lose that much, then you are inducing a Q wave in there. That has happened here. After proper placement, there's appearance of a small R in V2 and very smallish R in V1. So the patient actually did not have an old anteroseptal MI. Look at this one. Again, it's the same thing. Elderly patient presenting like this, and if you have this type of ECG, you may think the patient have an old anteroseptal MI. Look at this one. Now, the proper placement, voila, the R wave has reappeared. You have cured an MI. The patient actually did not have a old anteroseptal MI. Later on, we did the echo and find out, yes, it's correct. What about other type of lead transposition? Sometimes V1, V2 are transposed. Look at this one. The R wave in V1 is bigger than the R wave in V2. Then again, the V3 R wave is quite big. What has happened? After correction, V2 has become V1, V1 has become V2. And for fun, if you want to record a ECG lead, put V5 in V1 and V1 in V5 and find out yourself what happened to the ECG. You'll find it quite funny, but sometimes it may confuse you. Noise in the ECG, look at the lead 2, which we use for a rhythm strip to decide about the rhythm. Sometimes the baseline is disturbed. This is very common, and this is usually due to poor earthing quality of the electrical line. So in this ECG, it doesn't produce that much of a problem. But what about this one? You should not be interpreting any ECG that presents like this sort of electrical disturbance. You should ask for a new ECG. Computer is generating a report, but never ever trust like that. Look, trust your own eyes. Now we have established that the ECG I'm going to see is quite all right. I'm going to start interpretation. We should start a systematic way. Rate, rhythm, axis, P-wave and PR interval, Qrs complexes, ST segment, T-wave, and others. Let's go in. Let's have some recapitulation. The P-wave represents atrial depolarization. We know the PR interval is the time from onset of atrial depolarization to onset of ventricular depolarization. The Qrs complex represents ventricular depolarization. The Qrs duration is the duration of ventricular activation. The STT wave represents ventricular repolarization. The QT interval is the duration of ventricular activation and recovery. The U wave perhaps represent the after depolarization in the ventricles. Measurements, we know about that. The heart rate is usually 60 to 90 beats per minute. The PR interval should be 120 to 200 millisecond. QRS duration should be less than 100 millisecond. The QT interval should be 440 to 460 millisecond with some gender difference. The QRS axis at most minus 30 degree to 110 degree and mostly between 0 to 90 degree. This much we know, and this is the information we should be keeping in our mind. We start with the rate. State the ventricular rate. If needed, the atrial rate. PF rate we know usually it should be normally between 60 to 100. The rate, if it's less than 60 and if the rhythm is sinus, it's sinus bradycardia. If it's more than 100, it's sinus tachycardia. How do we calculate it? For regular rhythm, we can use these formulas. We all know that. And for irregular rhythm, the number of R waves in 10 seconds. Why 10 seconds? The ECG paper that we see nowadays actually record 10 seconds of ECG. So all the complexes in rhythm strip in that 10-second period, if we multiply by 6, we get the heart rate in 1 minute. Or in a regular case, very simple. The RR interval, the number of big boxes can be used to reach the heart rate. If the interval is 1 box, the rate is 300, 2 box 150, 3 box 100, 75, 60, 50, 45. And that's enough because when you reach it's more than the difference between RR boxes interval is more than rate is less than 45. The patient is in jeopardy. So it's a very easy one. We can count one R wave that falls on a line and find out how many boxes are there. There will be some 2 or 3 number of difference, but it doesn't matter. What's about 72 per minute and 75 per minute? Almost same, isn't it? Look at this one. This patient has a regular rate. We can count it easily, or we can count the boxes in between the large boxes. We can count the date. Now, this same patient, now the patient have alternating sinus Qrs complexes and an ectopic beat, an atrial ectopic. How should we count the rate? Same thing. Count all the complexes in the bottom rhythm strip and multiply by 6 and you will get the heart rate quite nicely. Look at this one, irregular rate. What about this one? When we mean heart rate, we mean the ventricular rate. We have to count the ventricular complexes. And what are the ventricular complexes? Here we are in trouble. So we have to look at the previous one and find out which one is the sinus complex. Sinus node activated followed by Qrs complex. That's what I'm calling sinus complex. Here in the bottom rhythm strip, we are finding there are sinus complexes, there are abnormal complexes. We have to count all of them and multiply by 6. That's the heart rate. That's the rate. Now what about the rhythm? State the basic rhythm. Is it sinus or is it non-sinus? Identify additional rhythm. For example, in a sinus rhythm, there can be PVC and PSC. We have to say that. Consider all the rhythm events from atria, AV junction, and ventricle. Looking at the Qrs complex, we can say this is a supraventricular beat, this is a ventricular beat, this is a pacing beat, etc. So, how can we classify it? Sinus rhythm, we know all the Qrs complexes are preceded by a P wave, and there will be actually lectures on each component of the ECG graph. So I'll be actually rather giving you a outline of what we can do. Sinus rhythm, we can have sinus rhythm with irregularity that can be regularly regular or irregularly regular, or it can be a non-sinus rhythm. There is no P wave. That can be narrow and regular like SVT, or that can be wide and regular like VT, or it can be regular AF or VF, or it can be a pacing rhythm. This is the classical normal sinus rhythm. Narrow Qrs complex or the Qrs complexes are preceded by P wave, and the P waves are upright in lead 1 and 2. So there's a normal sinus rhythm. What about this one? Well, it looks like every Qrs complex has a P wave in front, but the rate is quite higher. And so look at this one, the RI interval less than 3 boxes, 300, 150, 100, a little bit more than 100. So it's sinus tachycardia. Now look at the heart rate. There is 109 beats per minute. We are correct. We have made it only at having at a loop. What about this one? Look at the lead one. First two complexes, they are quite all right, but then there is quite a gap. But all the Qrs complexes are preceded by a P wave, which is very normal looking. So this is sinus rhythm, but the rate is low, less than 60. So it's sinus bradycardia. What about this one? We find there is a narrow complex and there is a wideish complex. The narrow complex, the smallish one, is preceded by a P wave. So there's a sinus rhythm, sinus complex. And the next one coming quite very quickly and very wideish. So there's a ventricular complex. So there's regular, normal, and abnormal complex alternation. There's ventricular bigeminy, sinus and ventricular rhythm alternating. What about this one? It looks like wideish complex all over. But look at the bottom street. You find out 4 big complex, wideish complex, then a PQRS T combination. So that's a sinus beat followed by 4 abnormal beat. Again a sinus beat followed by 5 abnormal beat. Again a sinus beat. So the basic rhythm is sinus, but we are having bouts of abnormal complexes, non-sustained VT. What about this one? We have seen this ECG before, isn't it? And we are in trouble. Which one is sinus, which one is not? Can I be sure? Take help from previous ECG or any other ECG that's previously present with a normal rhythm. Find out how the normal Qrs complex looks like. Then go back again and find out which one is the sinus, which one is not, and the rest are wideish complexes are actually ventricular complexes. So that's a difficult looking ECG, but if you go logically, it will become simpler. Here again, we have looked at this ECG before. There is a slightly irregular, but the irregularity is very regularly irregular. There's a PQRST followed by a narrow complex, which comes a little bit, seems to be earlier, and we do not see a definite PUF before, and that's followed by a little bit wideish gap, then again a PQRST complex. So that's normal sinus beat followed by a narrow, similar looking QRS complex, alternating this atrial bigeminy. What about this one? Narrow complex, very fast rhythm, but very irregular. And the irregularity is very irregular. That's the classical atrial fibrillation with fast ventricular rate. We do not see a regular P wave. What about this one? Sometimes atrial fibrillation, when controlled, may have relatively regular complexes. We may confuse them as an occasional fibrillatory wave, we can confuse them as P waves. Look at the V2 second beat. It looks like that there is a P wave before the QRS complex. It's not. You have to have P wave at least regularly, at least 3 or more complexes in the whole 10-second period, which clearly determines that it's coming from the sinus complex. That's not present in the rhythm strip. So there's atrial fibrillation but controlled ventricular rate. What about this one? It seems to be a very regular rhythm, but very wideish. No normal looking complexes. That wide complex regular tachycardia. What about this one? Whenever we find bradycardia, we have to be sure, is it sinus bradycardia? Is the P waves are too many for the QRS complexes? So you have to look at rhythm strip. Looking at the lead to rhythm strip, I may or may not be sure, but keep looking. First, second, third, fourth. In the fourth beat in lead 2, you find that the T wave seems to be bifurcated, fourth and fifth. That means there is actually P wave in between. Fifth, sixth, seventh, you can find it clearly. There is P-P interval is regular, QRS complex is regular, but the PR interval is very fixed. So there is 2:1 every block. Every alternate P wave is non-conducted. What about this one? Wideish gap, totally flattened. Is it sinus pause? But look at the middle complexes rhythm. There are multiple P wave scenes in between the RR complexes. So there is actually high grade FE block. Otherwise, I could have called a sinus pause. That's the way you should be looking at it. What about this one? Bradycardia is present. And looking at the bottom strip, we can clearly see the P waves are very regular. The QRS complexes are pretty regular. The PR intervals are very variable. They are going on their own. They are not taking care of each other. So there's a complete heart block. Bradycardia is due to that. I'm going into the second section. Because of the complexity, I have to divide it into 2 parts. I can reach it. Yeah. Can you see it? Excuse me,
Yes, sir.
Tushar, can you see it?
Yes, sir. Yes, sir. Yes, sir. Okay.
So we have taken care of the rate, the rhythm. Now look at the axis. What is an axis? The axis is the overall major direction of the electrical activity of the heart. Normal axis, I have told, it's between 0 to 90, completely normal, but minus 30 to 110, minus 30 to plus 110. That can be all right. So how to determine axis? That's the way you can look at it. There's a picture you can remember, but make it a little bit more simpler. If you look at, I don't have to look anymore except lead 1 and 2. If both are positive, lead 1 and lead 2, the QRS complex is normal, axis is normal. if it is Qs complex is negative in lead 1, the current is going away from the left side, from lead 1 to the opposite direction. That means right axis deviation. Look at the beforehand. Lead 1 positive, current is going to the left. Lead 2 positive, current is going to the left and down. That's between 0 to 90 degrees, definitely present. So it's normal. And here, the current is going away from the lead 1 towards the right side. So it should be positive in inferior 1, and that's the thing we are seeing. That's right axis deviation. What about this one? The right axis deviation in this case, that's a 28-year-old male. Look at the P1. There is a very tall R, so that indicates there may be right ventricular hypertrophy with right axis deviation. Now look at the P waves. The P waves in lead 2 is very sharp pointed, suggesting right atrial enlargement. But in V1, the negative component is also quite big. So there is biatrial enlargement. There is also left atrial enlargement. How can that happen? What about the context of mitral stenosis with severe pulmonary hypertension? You will get left atrial enlargement, right ventricular hypertrophy, right atrial enlargement. That's what you are getting. Now look at this one. The Qs complex is negative, so there's right axis deviation. Why the right axis deviation? The R wave is V1 is positive, so there's right ventricular hypertrophy. But why the right ventricular hypertrophy? Look at the P wave. The P wave in the V1 doesn't indicate any left atrial enlargement, but is sharp and pointed. In lead 2, it's sharp and pointed, though not big. So there's very likely there is some right atrial enlargement. Actually, that patient have primary pulmonary hypertension. Look at this one. Qs complex is positive in lead 1, it's negative in lead 2. So there is left axis deviation, and it's associated with actually left bundle branch block. Now, after axis, we should go into the waveform. That means starting with the P wave. For waveform description, carefully analyze the 12-bit ECG for abnormalities in each of the waveforms in the order in which they appear. P waves, are they too wide, too tall, look funny? That is, are they ectopic? Qrs complexes, look for pathologic Q waves, look for abnormal voltages or any other changes. Look at the ST segment. Is there any abnormal elevation or depression? Look at the T wave. Is it inverted? Is it too tall or flattened? Then look at the U wave. Is it too prominent? For P wave, the first and foremost is P wave present before every Qrs complex, or P wave is absent or totally absent? Is there any change in the P wave morphology? That means, is there any left atrial or right atrial enlargement or ectopic origin? And also look at the peer interval. Is it normal or prolonged or shortened? In this ECG, looking at the P waves, why do we look at the P wave? We look at it in the lead 2 and V1 particularly, sometimes in AVF2. In lead 2, the P wave seems to be a little bit pointed. But in V1, there is clear-cut enlargement of the evidence of enlargement of the left atrium. We will talk about individual chamber enlargement and others in different lectures. So I'm not going to talk about that. But what I'm pointing out that if you have a look at this one, this can suggest what is the problem. Now, this patient had a left atrial enlargement. With left atrial enlargement, is there any left ventricular enlargement or right ventricular enlargement? We have seen previous example where left atrial enlargement associated with RVH suggests the diagnosis of mitral stenosis with pulmonary hypertension. What about this one? There is very tall R in V6. V5 is not recorded properly, isn't it? It's kind of cut short. But most interesting thing is you have got a upright T wave. It seems like a volume overload pattern. Does the patient have MR then? Where we can get a dilated volume overload pattern LV and also dilated LA? Yes, that's the truth here. Echo shows mitral regurgitation of this patient. He actually had Marfanoid feature with eccentric MR, very dilated LV. How dilated? LA is 48 millimeter, which should be less than 40 millimeter. LVIDT is 65 millimeter, which should be less than 55 millimeter. So from looking at the ECG, actually I see the patient in the in my chamber. The first thing I cried out, hey, does the patient have MR? Just looking at the ECG. Now it is because of the COVID era, when we cannot examine each and every patient without precaution, this insight from ECG and other things really helps you to decide which patient to examine very thoroughly and which patient not. What about this one? This patient, in lead 2, there is a pointed, sharp pointed P wave. Why is that? The patient has in V1 evidence of bilateral enlargement. We have talked about it. This patient we have talked about actually have mitral stenosis with severe pulmonary hypertension. But looking at the ECG, you can have some grasp of what's happening with the patient. Now let's go into Qrs complex. PR interval, we have to look at it. Normally, I say that the 0.12 to 0.20 second, that means 120 to 200 millisecond. 3 to 5 small square, isn't it? If it is more, it's prolonged, 1st-degree heart block. If it is less than 3, very short, very narrow, we'll look for delta wave, isn't it? So if there's any short pair interval syndromes. After that, look at the Qrs complexes. How do we look at the Qrs complex? Are all the Qrs complexes in a particular lead similar? Is there any evidence of ventricular chamber enlargement? Is the Qrs complex wide? If there is there any bundle branch block, either left bundle or right bundle? What is the axis? Is there any Q wave? Is there any delta wave? Is it a paced complex? That's a very normal looking ECG. Narrow complex, all the Qrs complexes are preceded by P wave, a very normal looking T waves. There's normal sinus rhythm. What about this one? You get a whitish Qrs complex with persistent S wave in left ventricular leads, lead 1, AVL 5, 6. And in V1, you get RSR prime, the M pattern. That's the classical complete right bundle branch block. If the white is less than 120 millisecond, then it's incomplete RBBB. Is it important, incomplete and complete? Yes, because incomplete RBBB may be normal pattern, normal variation, but complete RBBB ultimately is associated with cardiac disease and some morbidity in the long term. What about this one? The Qrs complex in lead 1 is very whitish. Excuse me. The Qrs complex in the left ventricular lead, wide R wave. And there's left bundle branch block. We have lectures on individual components separately, so we'll not be elaborating in each other. What about evidence of chamber enlargement? Very tallish R waves in left ventricular leads, either 1 AVL or 5, 6, V5, V6. Here it is present. In V5, V6, it seems to be there is some widish complexes. What about the T waves? Associated T waves suggest that associated T wave changes, ST segment changes suggest there is left ventricular hypertrophy. What about this one? There is right axis deviation. There is taller in V1. Both these suggest right ventricular hypertrophy and supported by the nature of the P wave, which is sharp and pointed, suggesting right atrial enlargement as well. Actually, the patient have primary pulmonary hypertension. After chamber enlargement, what else do we look for? Is there Q wave? In the limb leads, we do not find any problem except in FVL there seems to be a widish Q. But in V1, V2, V4, V5, we find there is a Qs complex. The Q wave is merging, there is no R wave. So there is loss of R wave totally with presence of Q. There's big old anterior MI. Actually, the patient has MI long before. So this persistence of ST segment elevation also pointing out the patient have LV aneurysm, which was true in this case. How this helps? These patients are very likely to develop LV dysfunction, chronic heart failure, arrhythmias, sudden death, thromboembolic complications, and whatnot. So they need aggressive management. What about this one? We get a Q wave in lead 2, 3 AVF. So that's inferior MI. But whenever you see inferior MI, we have to look for is there any other association. There is also a smallish Q wave in V5, V6. Particularly V6 seems to have quite a Q wave. And there is a tall R in V2 with an upright 2F, which suggests the patient may have posterior MI. We have done the posterior lead, V7, V8, V9, and find out there is presence of QF. So this patient actually have inferior posterior MI. That means a larger area of muscle is involved. What about other changes? For example, in this patient, the Qrs complex is a little bit funny looking in anterior leads, V1, V2, V3. This classical pattern always put the diagnosis of Brugada in mind. And this is important. For this type of patient, a particularly prone to develop fatal ventricular arrhythmias and sudden death. So we should keep this picture patterned in our mind so that whenever we see it, we can diagnose it instantly and ask the patient pointed question about arrhythmias, about sudden cardiac death in the family and other things. What about this one? There is a sharp spike in front of each Qrs complex. So that's easy. It's a paced ECG. I do not find any relationship with P wave and actually could not find a P wave. So this could be only ventricular pacing. What about this one? There is positive Qrs complex in one APL, but all over the chest is, all those are negative waves. And what is this the interventricular conduction delay, or is this LBBB pattern looking at VL? No, this is not LBBB. Look at V5, V6. You find a very smallish spike in front of the Qrs complex. And you have to look for it, otherwise you could not find it. What about the bottom strip? Why there is rapid rate on the right hand side? Actually, we have put the magnet over the ECG asynchronous mode, and we find out the rate is increased around 98, that means 100. That means battery voltage is quite all right. This is a pacing ECG. Now look at this one. Similarly, LBBB pattern, but all the Qrs complexes in chest leads are negative, and looking at it very carefully, we find there's a smallish spike in front of Qrs complex. At the bottom, you find that every Qrs complex is preceded by a P wave. And if you look very carefully, you'll find out there is a very small spike in front of the P waves too. That means this is a dual chamber paced ECG, pacing both the atria and ventricle quite nicely. Now comes to the ST segment. Is it elevated or is it depressed? ST depression, ST elevation is very specific, and we are afraid one get the ST elevation with chest pain. That's acute MI. Well, what about ST depression? There are three types of ST depression. American Heart Association classified it as the upsloping. The ST segment is upsloping more than 1 millimeter, and that should be measured 0.08 second after the end of the Qrs complex. But this is not actually very diagnostic of acute ischemia, because there is 30 to 40% error rate. But if you get a horizontal ST depression, that's very much suggestive that this is acute ischemia. Very specific, very low error rate, around 95 to 98% specific. What about downsloping ST depression? This could be associated with ventricular hypertrophy without acute ischemia. So there is 5 to 10% error of diagnosing ischemia from it. That could be only strain, relative ischemia. What about the ECG changes in acute coronary syndrome? Because it's very important for saving lives. Look at the normal one. There can be horizontal ST depression. There can be downsloping ST depression. There could be TOP inversion. All those can be found in unstable angina or non-ST-MI. And if we get the ST elevation, of course that's ST elevated MI, or in rare cases, Prince metal angina. So in this ECG example, there's ST depression in 1, but in lead 2, there's ST elevation. So go to the inferior leads. Lead 3, ST elevation, AVF ST elevation. What about the anterior leads? There's also some ST elevation too. Particularly, we can say that this is at least definitely a case of acute ST elevated inferior MI. That anterior elevation could be related to RV branch occlusion, and the ST depression in 1 AVL V6 is reciprocal change, which also suggested the patient really have acute MI going on. What about this one? The ST elevation is present in 1. Always go to the similar leads. AVL, go to the similar lead 5-6 ST elevation. And how much ST elevation is present? It is present from V2 to V6, 1 AVL, extensive anterior wall MI, ST segment elevated MI. There is reciprocal ST depression should be there in inferior leads. Yes, it's present. 3 AVF, look at this. A particular ECG pattern we should be diagnosing very rapidly, because it carries very important information. Left main coronary artery stenosis or involvement. Typical ECG findings in severe left main coronary artery stenosis or occlusion include ST segment elevation in lead FER, which is more than V1, with widespread ST segment depression or maybe some anterior ST elevation. And this is very specific. This patient, a 64-year-old lady, presented to my chamber. She was quite all right when she come to my chamber, but he has to wait a while. Around half an hour later, when she started having chest pain, he was rushed in my chamber. We did the ECG immediately. We find out this feature. There's ST depression in 1 AVL, V4 to V6. There's also ST depression in lead 2 and AVF. So widespread ST depression that encompasses more than one coronary territory. So look at AVR. We find ST elevation in AVR. And that's clears the diagnosis. This patient have left main disease. She was immediately put into CCU, was stabilized, and done the angiogram immediately on the second day actually, and found out critical left main stenosis. She's already had a bypass and doing very well now. Another thing that we often missed is posterior MI. ST elevated MI in inferior leads, quite all right, but there is ST depression with tall R and upright T in V2, V3. This suggests posterior involvement. And if we do the posterior lead V7, 8, 9, look at this one on the right hand side, quite an ST elevation with Q wave. There is posterior MI, a big posterior MI. So his area of myocardium is jeopardized. And we also remember that there are many mimickers. That's important to know. Each will be talked about in future lectures, but we have to keep that in mind. QVS may not be pathological, particularly if it is present in lead 3. Sometimes the Q wave changes with deep inspiration. Look at the Q wave in lead 3 and AVF. After deep inspiration, the AVF has become upright. Look at the Qrs Complex in AVF. After deep inspiration, it has become upright. So there's not actually a pathological Q wave. We can get a Q wave in V1, which may be normal. But one thing we should be aware of is early repolarization in the ST segment changes. There is many types of early depolarization. The classical one is J-point elevation. There can be J-point notching, and that's the 4 types of J-point elevation you can get. And you have to identify them properly to prevent misdiagnosing them as anterior MI or inferior MI or something like that. This patient have both early repolarization changes in inferior leads and also the anterior leads, P4, 5, 6. So we have to be sure. There's another point of ST elevation where it becomes widespread. And whenever we get widespread ST elevation, look at AVR. There's PR segment depression and ST depression in AVR. PR segment elevation. That's very classical of pericarditis. Many of these patients are sometimes thrombolized in our country or may be mistaken as a acute MI, and there can be cath-lab activation, which doesn't need. Now go to the T wave. Is it too tall? Is it inverted or flattened, or is it too wide? Look at this one. The T wave in V2, V3, V4, ST elevated, very sharp, big looking, pointed T wave, hyperacute MI. If the patient has chest pain, no doubt, you have to activate the cath lab or go for thrombolysis. What about this one? Apparently quite all right, but T wave seems to be very bit pointed and little bit prominent. Actually, the patient have hyperkalemia. Take the history. The patient has CKD. So very likely the patient has hyperkalemia. So you check it out. It was not that raised, but it was more, nearly 6 in this patient. What about this one? Oh, I'm sorry about this inequality. This patient is very high potassium level, and they will go into many changes, wide Qrs complex and etc. if we do not treat it urgently. What's the importance? Looking at the ECG, the diagnosis of hyperkalemia should come into your mind as a diagnosis, and you should look into the ABG or do the electrolyte immediately. Otherwise, patient can have a very fatal cardiac event. What about T inversion? The T inversion here in the anterior leads with a biphasic T wave in V2 suggests this is the ischemic T wave changes in the LAT territory. What about this one? Trolley sharp, strain pattern, T inversion. That's classical of hypertrophy. You can get it with LVH due to aortic stenosis or hypertension, also hypertrophic cardiomyopathy. What about the QT interval? In this patient, how can we be sure the QT is important? We actually often do not look at it. Look at V1. The QT interval is more than 50% of the RR interval. That suggests This is very likely to be QT prolongation. Now look at the report in there. QT, corrected QT is 492 millisecond, corrected QTC is 662 millisecond. This patient may develop a fatal arrhythmia, so you have to be careful. What about this one? Wide-based T-wave inversion with QT prolongation. Look at the QT in V4, 5, 6, very prolonged. This is having a look at this patient. Look at the P waves. The P waves very, but in the chest list, very smallish. Could this be due to hypokalemia? Yes. In this particular patient, it was less than 2 millimole. What about this one? Here, there is QT prolongation, it seems. But if we look at V2, V3, V4, V5, the T wave seems a little bit funny and double peaked. Actually, there is prominent U wave marching on the shoulder of the T wave and simulating prolonged QT interval. There is actually prolonged QU, and that may not be actually related to prolonged QT. But whenever you have a prominent T wave, U wave, if you look at the potassium level, that patient can develop arrhythmia. So we just have gone through the whole from starting from the P wave and to the E wave in a rush. What's my take-home message? Understanding ECG is vital in becoming a successful physician. ECG interpretation can be challenging, but it can be fun if we follow a systematic approach. Our ECG study group is trying to highlight the fun part of ECG. Let us join together and flourish together in understanding ECG. Thank you, everybody.
Thank you, sir, for your nice and easier approach presentation, Art of Interpretation. It's really interesting that how easily and how interestingly we can approach to analyze an ECG. Thank you again, sir. I request Dr. Arun Maski sir to say a few words regarding the presentation. Maski sir.
Wadud is a good teacher, academician, and he has been taking these classes over a year. His classes is so nice. So I've told my MD residents in Nepal to join these classes. I hope many students, at least must be around 30, 40 students, they must have joined today. I don't know how many of them have joined. So these are very useful class. And thank you, Wadud. Thank you, Atahar Ali, and thank you, ECG study group for bringing this basic class. In fact, I'm also learning ECG. I've forgotten so much of ECG, and this ECG study group, I've been learning a lot. So thank you, Wadud, and your team for doing an excellent job. These lectures are fantastic. I don't have words to explain, and be grateful to you taking classes, our webinar classes to all our students here in Nepal. Thank you.
It's our pleasure. It's our pleasure.
Thank you, sir. Now I request Chowdhury Hafiz sir to say a few words regarding the presentation and his inputs.
তুষার, তোমার কথা কিন্তু খুব অল্প শোনা যাচ্ছে।
Sir, is it okay now?
Not yet. Wadud, can I make one correction?
Yes,
Wadud,
please. Yes, please.
One thing regarding the speed of the tracing, I think you have presented the reverse thing, as because if you make the paper slow, there will be more complexes recorded on a paper, and it will look like tachycardia. And if you speed up the
yes.
paper, then it will get widened and it will look like bradycardia. And as because I often do it in the cath lab monitor, everyone is habituated with 25, but I am habituated with 15.
No, thank you. That's correct. That's I think you were right.
Yeah.
I think that will be the eye of the EP because they do it all the time. Yeah,
Yes.
you are right. Hafiz Bhai, are
Hafiz
you
sir,
there?
He's sharing his
So,
screen.
so basically the SVT will look like VT if you speed up to 50.
Yeah.
So be careful. This is but I must tell you that we don't have much time, but Wadud summarized everything very well. So I am going to show you a couple of EKGs and basically to tackle this EKG after you pass the exam. The reason I'm saying this because EKG for some reason is most challenged in the exam, but I'm going to tell that EKG is one important bedside tool that you get with the patient as take this in totality. So with that in mind, let's say this. Let me I don't know my screen. Okay, 81-year-old came in with the hospital with fatigue and shortness of breath. So this is in a hospital where they had previous EKG. So they pulled the previous EKG below and then the current EKG on the left. And the ER physician got worried and called it a STEMI. So what is the next thing you do? Follow the same thing that Wadud mentioned. And as usual, he's an outstanding teacher and explains things very well. One thing I just want to add with what he said is that when in real life we deal with the EKG, take the clinical context. Very, very important. So what are the, anybody can jump in. So this patient has, if you look at the EKG at the previous one, on the right lower panel, there is looks like atrial fibrillation. And then on the left upper panel, to me, looks like atrial fibrillation. But why the ER physician calling STEMI? Because he thought that there is ST elevation. So this is 81-year-old. What are the possibilities in terms of management? And what is the best next step?
Hafiz Bhai,
Yeah.
I do disagree with your ER physicians as I don't find any ST elevation in the left upper panel ECG.
Okay.
To me, there is no ST elevation.
Yeah. And often in the night, this is a problem because we are not there. The ER physician is there. And I usually put the phone down, I call back and talk to the nurse. You know why? No disrespect to the ER physician, but from the nurse, I actually get the true story. Physicians often make this story up, such as vomiting in the emergency room. I hardly hear that vomiting is not coffee ground. When the doctor call it, they make it up. So no offense, but that sometimes I want to know the real story. So what do you, if you, Dr. Jamil, what do you think? What we should do to address this? Because our job is to make sure that the ER physician is satisfied.
As the lady is having fatigue and Qrs complex seems to be wider than the previous ECG.
Electrolyte and creatinine.
Electrolytes should be looked at and creatinine. And,
so potassium 6.7 by curve 12.
Yeah.
So this is important that you pick up this quick. So this patient with CVA, previous hypertension, diabetes, CKD, and some ST changes in the V2, V3, and then lead 1 AVL, right? So we thought that this is important, but fortunately the patient did not have any chest pain, but the ER was concerned about the ST segment. So the EKG was drawn later. They did not call. The ER resident actually wanted to wait for the lab, and the repeat EKG became like this. And then, as Professor Wadud Chowdhury mentioned, tall peaked T's, look at this evolution. And the longer you wait, you actually show very nicely that how it is evolving. So there was uremic pericarditis and hyperkalemia. Now, this one is very, very important. This patient was...
Do you want to send NT-proBNP in first patient looking at that ECG with the history?
Was that?
NT-proBNP in first case. Shortness of breath, 81 years old lady.
Yeah, so some of the hospitals, they do BNP, some say send it to pro-BNP. But
Hafiz Bhai, we should remember that in elderly population, the BNP is more than 80-100 is recognized that this patient have heart failure.
Yeah, yeah.
It's very much age related.
Yeah, so the age related, but generally the BNP cutoff less than 100 is, you can probably forget about, except in diastolic dysfunction, obese. But generally speaking, more than 500 you need to think about. But I say this: if you are thinking about MI, you don't look at the troponin. You just diagnose the MI. Similarly, for heart failure, you should not wait for the BNP, and that is an after phenomenon. So this is important because it raises a lot of questions about EKG interpretation and management. This patient was brought in unknown, and then EMS activated the STEMI, and this is the EKG. And they went through ACLS and got some pulse and blood pressure back. And they're asking us to go to the cath lab. So any comment?
There's Q-wave. Look at the FEF. There is a P-wave seen on the second row.
Yeah.
Perhaps.
Yeah. And then look at this, that this is all over. Actually, Rafique Bhai is not here, but I look at the computer generated diagnosis. Computer generated diagnosis was uncertain rhythm because computer could not figure out. So I was laughing. Then look at this. And one thing in EKG, as Wadud mentioned, if the repolarization is abnormal, depolarization is abnormal, remember the repolarization is going to be abnormal. This is very, very important thing to remember. If the depolarization is abnormal, repolarization is not going to be normal most of the time. So this, and then they got this rhythm, and then we need to decide. So this was bad, and I don't know whether you call it worse or you call it better. So I will take two kinds of answer. One is absolute EP way of answer, that you are desperate to make it right. The other one is functional. That means you have a comment and you have a workable diagnosis. And workable diagnosis means you embrace the differential and you can institute the therapy. So this morphology in the V1, and we are showing this often, that when there is right bundle, patients pre-existing right bundle. When the right bundle becomes changed with hyperkalemia, acidosis, or acute coronary syndrome, they start getting this rounding shape. And when the patient got a little better, you can see the right bundle branch is there. But we need to know what's going on with the patient. The patient had a temperature 103. It is actually, I actually collected this EKG from last week because Rafique Bhai said he'll not be here. So this, and Las Vegas temperature has gone up. And then a patient came in with this syncope brought in by the ambulance, but syncope is transient loss of consciousness, but the patient remains unconscious. So this is not syncope. Patient remains unconscious and getting resuscitation on levofed, dopamine, and this EKG, and the ER is asking us to take to the cath lab. What we do? And then in the process, patient got VFib, got shock. So what we did, in like any.
Hafiz bhai, you got muted.
I can't see anything.
Hafiz bhai, you got muted.
You can hear me now?
Yeah.
Okay. So what we do in this situation, you need to assess the patient in totality, that a patient who is febrile, unconscious, on vent now, and then look at the profound acidosis and the potassium high. LV at bedside was bad, and that is another reason for the ER doc to go after us and saying, take this patient, give supportive care, put Impella. But my question to you is that, think about utilizing resources. In all literature, when the pH is 7.1 or less, prognosis isn't bad. 6.9 is uniformly can be fatal. So this is, before we use resources, we really need to think about the utility of care. So let me show you this one. 59-year-old, this patient passed out, now fully alert, awake. And when in the ER, look at, this is the EKG baseline. He's known to have AFib on anticoagulation, and we don't know his LV function. He does not have any scar on the chest, and he doesn't have any device. Unknown patients, I always tell the fellows and residents that do an exam. Look at the patient. It is not cheating. It is not cheating that there is a scar mark, there is a pacemaker, there is a device, any history of previous procedures. 3 questions. Why the patient is here? Second question, did you have any cardiac procedures or diagnosis before? And third question, have you been to this hospital before or in any other hospital? We have now the EPIC medical record. You can click and then go and see EPIC anywhere, and that tells you in the area the patient has been in any other hospital. That tells you a lot. And in the ER, patient did this. So this is wide complex tachycardia. Any comment? I don't see any other faculty. Maybe I can ask Dr. Arun Maski.
Yeah, that baseline was AF. Now it has gone into wide complex tachycardia, and looks it's quite irregular. So we'll have to check baseline electrolytes and AVZ to find out whether there's any
Actually,
imbalances.
if you look at this, that there is some P wave here, And if you look at the RR interval, it's pretty regular and it is pretty northwest axis. So we actually thought this is VT, and then we gave amiodarone and then Lido and got this patient back into narrow complex. So narrow complex, LV function was bad. And then we did the angiogram and then non-ischemic cardiomyopathy. And then we put the patient, yeah.
This looks like atrial fibrillation.
Yes.
Okay.
So atrial fibrillation, and then patient went into VTAC and sustained VTAC that we are about to cardiovert, but the patient blood pressure was normal. So we gave amio and then Lido, and then he broke. And then we did the angiogram to see whether there is any ischemic substrate. We did not see any LV globally dysfunction. Sustained VT, so we put an ICD. So EKG, from last night, I brought this EKG and I'll tell you some stories. This is an EKG that a Spanish speaking guy and then chest pain, and look at the 2-3 AVF. This 2-3 AVF, but precordial leads, no reciprocal changes. Lead 1 AVL, no changes. So it can be, life is not easy. It can be tough. So what do you think about this EKG?
Sir, I like to comment previous ECG, sir. Is there any fragmented QRS complex in lead 2-3? Previous
this
ECG.
one?
Previous is, yes, sir. Lead 2-3, fragmented QRS complex, and probably ultimately culminate to VT. Scarred myocardium. Might be.
So excellent question, and I'm not an electrophysiology guy. So there is depolarization abnormality, right? There is you can call it interventricular conduction defect, whether there is a VT substrate. So that was our question to the electrophysiology guy, but because the EF is bad and it was sustained VT, they said it is probably better to put an ICD rather than go to VT ablation. I will show you other cases where we had patient coronary artery bypass surgery before, scar, and now has VT. Patient already has by ICD and is still getting recurrent VT. And then we were desperate to find the source of the VT, because these are all usually the scar-related re-entry VT. And in those cases, we do endocardial mapping, sometimes epicardial mapping, and you can ablate the VT. So this patient, for the sake of time, I'm just showing you that if there is a question about chest pain and then doubtful EKG like this, what will be our way to tackle this patient? Because in the middle of the night, they call for a STEMI and it's a headache. Will you give? So I look at this and I say, it really does not fulfill thrombolytic criteria. It does not. So will you cath? I mean, that's your judgment call. My partner ended up doing cath and coronaries are fine. So sometimes it can be difficult. So now I show you this one. I had our fellows graduation yesterday. And before just we start the program, STEMI pager went off and we are all in a hotel doing the fellows graduation, and this EKG, that means at least 5-6 of us will have to leave, spoiling the program. What do you think, this EKG? 50 something plus. Let me see whether the patient has an age.
What are the symptoms of this patient?
Coming with chest pain.
Yes.
And the blood pressure 160, 100, and heart rate like 60 something. and then patient had chest pain.
Looks like a pericarditis, widespread.
It's not really widespread.
No, if you look at 2, 3
In 2,
AVF,
3 AVF, it is concavity up, and
then 4, 5, 6, even
V1 to
weight 3.
is elevated.
So I don't see any concave upwards ST changes. There is no PR depression in the 2, 3 AVF.
Yeah.
There is no PR elevation. And the chest pain actually is not like pericarditis type pain. It's like patient is saying that it's like feeling heavy and complaining of pain, like 5, 6 out of 10. Was that?
V1 to V3 seems like ischemic ST elevation.
V1 to V3.
Yes,
Yeah.
sir.
So
V2, V3 going to be ST elevation seems to be.
In the very early stage,
Subsequently
it looks
ECG.
like that.
But otherwise,
so is it good enough to give lytics or going to the cath lab?
no, sir.
No, sir.
So let me tell you, sometimes life is not easy. I sometimes don't give any heparin or anything in the ER. I just give aspirin and take to the cath lab and then decide after the cath. Because I ask myself, if it is not a lytic indication, then why I'm giving heparin, right? And here I have a different problem. Should I spoil the party or should I go to the cath lab? I'm not on call. I can ask one of my partners to go, but it's still an issue. So what I did, I distributed this EKG to all my faculty and the third-year fellows, outgoing fellows. And overwhelmingly, the vote was that this is not a STEMI, which I agree. This is LVH related. So we sent a fellow who was in the hospital to do a bedside echo, mild LVH, and rather hyperdynamic LV, if anything. Good wall motion, including apex good. And I can tell you, early morning, I checked 2 troponins so far negative. So sometimes we need to combine other information to decide, because if it is very straightforward, I would not argue. With that in mind, this is the patient that little late in the night, a different hospital, patient was brought in by the ambulance after wife called the ambulance with chest pain. The patient does not look happy and we don't have any previous EKG. Wadud mentioned about right bundle, and you would agree that this is sinus rhythm right bundle. Question is there any STEMI? So STEMI
No
actually,
STEMI.
there is no STEMI in the
No
EKG.
STEMI.
The EKG is always suggestion of ST elevation. There is no MI in the EKG. MI is a clinical diagnosis. When the clinical diagnosis is consistent with the ST elevation that is in the EKG, we call it STEMI EKG. Because without the clinical, no one should read STEMI in the EKG. It's very important because there are many other differential of ST elevation, and all ST elevations are not equal. So in this case, look at this, the ST elevation in V1, V2 is present, right? And the important thing, sometimes we ignore this. This is PVC. These are the PVCs, and not very infrequent. Rather, even in one rhythm strip, we see 2 PVCs, and this is the EKG that you look at V1, V2, V3, same patient. This is ST elevation. So can we read ST elevation from with the pre-existing right bundle? Of course, we
Yes.
can read. And this was a LAD that was subtotal, and patient did fine. So I will finish with this one. This is a patient with 60-year-old with on hyperlipidemia on medication, came in with this EKG. So if you can look at this, mainly sinus rhythm, and then goes into white complex, and then remains white complex towards the end of this strip. And I
can I make a comment, sir?
Yeah.
LBB pattern ECG with along with FIV with first ventricular rate.
Okay.
LBB with FIV with first ventricular rate seems to me.
Okay.
Sir.
And so let's look at this. So then this EKG looks like sinus here, right? Sinus here, non-specific ST changes. And then we did all the workup. And then we say the EKG is, this is the one that I actually mentioned that we should give a differential, because it looks like irregular left bundle. To me, it looks like the AFib with left bundle and intermittent. What is the cause for that? So I usually ask the question, why the patient came into us? Shortness of breath, fatigue. And then little distressed, but doesn't complain of any chest pain. So is there anything emergency here? Can it be acute coronary syndrome giving this left bundle and tachycardia?
What is the chest pain?
Was that Wadud?
Was there any chest pain?
So complaint of shortness of breath, diaphoretic and pale. And I actually was not in the bedside, but the HNP does not say patient had chest pain. So the EKG subsequently with analgesics and little diuretics and morphine and Zofran came like this. And this was the troponin. But this is actually small rise because these are like 5th generation and you divide that by 1,000. So it's a very small troponin. So the cath was done because whether there is any ischemia or not, What I wanted to tell you that it is not a bad thing to always go through the white complex tachycardia. So this is our fellows exercise, VT, SVT with aberration, SVT with pre-excitation, SVT with ventricular pacing and artifact. But I tell you, this is from the book. But when the white complex tachycardia is irregular, then irregularly irregular, then you should also entertain bundle branch block with atrial fibrillation. So the cath was done because I don't know, Wadud, would you have done cath in this patient? Intermittent.
Well, given the scenario, it's better to have a cath.
Yeah, I agree. I saw the LV function. and to start with, and then you see there is a LAD lesion in the almost like in the proximal part, and then we got the IFR is good, and then we did not do any intervention. LV function was bad. I did not want to do the cath. The reason is that the LV function was globally poor, EF 15-20%. If it is an acute event, the LV globally will not be that bad. And then the patient acknowledged that he drinks a lot of alcohol.
Alcoholic.
and then this. Now, the one fellow asked me this question: will you give an ICD to this patient? And I was little surprised, but at the same time, I was actually going to answer the question. So will you give an ICD to this patient?
When the patient is stabilized, the Qrs complexes are very narrow. And if there is any precipitating factor for that arrhythmia, then that's better be taken care of. And it's alcoholic cardiomyopathy. If the primary treatment is abstinence and the supplements of vitamins like that.
And this is a very, because we did everything as Wadud mentioned, that it is not an ischemic etiology. Now we call this ischemic cardiomyopathy. I think that's a misnomer to me. Ischemic cardiomyopathy, it is better to say CAD related cardiomyopathy. Because if it is a cabbage patient, scar, bad EF, there is no ischemia. We still call it ischemic cardiomyopathy. But where is the ischemia? So I rather call it CAD related cardiomyopathy. And there is a cohort where there is no CAD related cardiomyopathy. And there is a cohort where you will see this overlap, disproportionate cardiomyopathy. CAD is there, maybe an OM 90%, but the non-ischemia is everywhere. Every other vessel is good. So I call that disproportionate cardiomyopathy compared to the observed CAD. And one of the other things that we also see, what we call the disproportionate cardiomyopathy, sometimes can fool us. And this is well known in the literature, that LAD infarcted and then over time remodel. So that LAD 40%, then 5 years later, without treatment, this LV remodeled so much that LVEF now 25%. And that is because of that reason. So it is a lot of overlap. But in this patient, I thought that this is not a VT. So if it is not a VT, then for AFib with left bundle aberrancy, and another sort of nomenclature problem we have is the bundle branch block. Actually, if you think about it, there is no bundle branch block. Conduction is still going. Conduction is just delayed. So if it is a left bundle branch block, that is not the left bundle still conducting, but it is very delayed. That's why we see that pattern. Right bundle, the conduction is delayed. Left anterior fascicular block, the left anterior fascicle, the conduction is delayed. That's why we see that EKG pattern. But nevertheless, I just thought that this patient needs alcohol cessation and give all the good medicine, follow up. And if the LV function comes back, then we don't need to give any ICD. But the rhythm is important, because we cannot say that this is a sustained VT. Then it will be wrong, because it is actually AFib with bundle branch block. So someone mentioned that AFib bundle branch, that diagnosis is key, that we don't get fooled by the white complex. That's all I have.
Thank you, Hafiz Bhai.
So I have one question to you, Hafiz Bhai. How often do you do CT scan, CT coronary angio in your setting when you have a doubt whether this patient, the likelihood of coronary artery disease is less?
So this is whole talk about application of CT in the emergency room. But the CT angio as an outpatient, we do a lot as an outpatient. But CT angio from the ER, looking at the coronary, is actually, you need to be careful about how you interpret. I would say this, it is better to do CT angio when your clinical pretest probability for significant coronary disease is actually low, or you are thinking about anomalous coronary, or you want to kill 2 or 3 birds in one, is as if like exclude dissection and then coronaries. But as you know, the CT angio, the acquisition of the images is difficult if you want to do 2-3 things at the same time. We call it CT angio with coronary overread, but the software has to be there so that you can do the CT angio for ruling out dissection, but then you can extract the images so you can interpret the coronaries well. So it is very good and good tool to exclude calcified lesions, distal left main, and then prox epicardial lesions. So generally speaking, we try not to. And if there is no problem, we'd rather go and do the coronary angiogram and then exclude that way.
I have a question, sir.
Yeah.
If in the setting of acute coronary syndrome like chest pain or severe chest pain and ECG LVB pattern and troponin raised, in that case, lytics or primary PCI now is it indicated?
Okay,
In
so
onset LVB, chest
yeah,
pain, like acute coronary syndrome, severe chest pain.
so let me answer that question in 2 different ways, because if I'm in a center where 24-hour cath lab is present and there is no significant issues in terms of doing the diagnostic cath, I think my life is easy, because clinically you are saying left bundle, patient is still having chest pain, you do not meet Garbosa criteria, but is still having chest pain. I mean, the cath lab diagnostic is not a big deal, to be honest. But it is a big deal to give this patient thrombolytics because it has its upfront cost. I would then go by the history, how long, is there anything in terms of 6 hours or 12 hours, any old EKG present, is there any Garbosa criteria? I would be more careful, and particularly if the patient is above 75 and if he is a baseline echo possible, then all these in totality, I'll be very careful. I would not give just because of the left bundle and jump on giving lytics, because safety first.
Thank you, sir.
That's important. Actually, in this case, clinical context and echo, these 2 things really help.
Yeah.
Uh,
And I think, Wadud, you will agree that God will not be that unkind to have a left bundle and EF like 10%. Unless there is a scar mark, previous cabbage, multiple stents, previous interventions, unless that, a fresh MI with left bundle, EF is not going to be 10-20%. And you will see some regionality, But if it is alcoholic cardiomyopathy, like
Yeah.
our patients, is a global EF 10, 20, 25%, you know what you are dealing with.
Tushar, তুমি
Thank you,
conclude
sir.
করো?
Thank you, Hafiz sir and Abdul Wadud Chowdhury sir for their nice presentation. Before concluding our session, again, I'd like to remind our participants and the dear panelists that Atahar sir is still in hospital with his mother, who is struggling with his.
তুষার তোমার কথা শোনা যাচ্ছে না।
Sound low, sound.
Sir, is it okay now?
Yes.
Okay. Before concluding this session, I again like to remind our participants that our respected teacher, Professor Atahar Ali sir, is in Evercare Hospital with his mother. His mother is fighting against COVID. We all should pray for her recovery. And I hope in the coming 24 hours, we'll hear some good news from Atahar sir. And with this, I'd like to request Abdul Chowdhury sir to conclude our session. And next week, again, we'll meet. Thank you.
Thank you, Hafiz Bhai, for being with us, and all the other faculties, including Professor Arun Maski, Professor Jamil, and Dr. Gobindo, Professor Makaddas and Sadi Bhai. Thank you, everyone.
আমি একটু কথা বলি, শুনো।
Yes, sir.
তুমি যখন কথা পড়াও, আমি শুনি, তোমার পড়ানোর স্টাইলের ভিতরে একটা সম্মোহনী শক্তি আছে, বুঝছো? তো আমি তোমার কাছে অ্যাপোলজি চাচ্ছি, কারণ তুমি যখন শুরু করছিলা তখন পার্টিসিপেন্ট ছিল 170-75, আমি যখন শেষ করলাম তখন 92। আই এম সরি ভাই।
It's already 11:30, so the people have to, the basically younger people, they have to take the food and everything, so I don't blame them.
আমি জানি না জামিল ভাই বা অরুণ মাস্কি, when Wadud teaches, even if I know or I don't know, I kind of still listen.
Yeah,
don't you agree? He has a very powerful way of communication, you know.
I do agree.
Hafiz bhai, from next time you should start the session, you'll get 180. Wadud will end with less number.
One thing I like to share,
রুনা লাইলার পরে গান গাইতে নেই, রুনা লাইলার পরে গান গাইতে নেই।
স্যার আমি ওয়াদুদ স্যার, আমরা যখন থার্ড স্টুডেন্ট ছিলাম, আর এমডি থার্ড পার্টের স্টুডেন্ট ছিলাম, আমাদের সময় তো সেকেন্ড পার্ট, থার্ড পার্ট, ফার্স্ট পার্ট ছিল। তো স্যার বলতেন ইসিজি সম্পর্কে, যে ইসিজি দেখে 1 থেকে 2 পাতার একটা রচনা লেখা যায়, মানে এত ইনফরমেশন আমরা ইসিজি থেকে পেতে পারি যদি মাইনুটলি আমরা ইসিজিটা রিড আউট করতে পারি আর কি। এটা কথা বললাম আর কি, মনে আছে স্যার বলতেন প্রায়, যে আসলে অনেক কিছুই মিস করে যায়, ওভারলুক করে যায় ইসিজি দেখার সময়। Thank you
everyone. We are hoping that in the next session, next week, Tushar, review, can you say the next lecture will be giving?
Yes, sir. The next lecture is correlation of ECG with anatomy and physiology.
It's supposed to be Professor Atahar Bhai. I'm not sure he'll be able to do that. We'll manage with the next one or someone like that who will be giving that one. Let's hope for that. Hafiz Bhai, আপনার next session-এর জন্য আপনি ready থাকেন না হয় দরকার পড়লে।
ওয়াদুদ, তোমাকে বলি, কালকে ফেলোরা আমাকে গিফট দিছে, বইটা খুব ইন্টারেস্টিং, এভরি পেশেন্ট টেলস এ স্টোরি। এর আগে আমাকে ওই একটা কি বলে অ্যাপল ওয়াচ দিছে, স্টেথোস্কোপ। কালকে যারা আউটগোয়িং ফেলো যারা বললো তোমাকে আমরা এভরি পেশেন্ট টেলস এ স্টোরি, এই বইটা দিই। দিস ইজ অ্যাকচুয়ালি গুড, আই হ্যাভ নট রেড ইট, ইটস আতুল গওয়ান্ডে, অ্যাকচুয়ালি ইটস এ ভেরি গুড বুক, এভরি পেশেন্ট টেলস এ স্টোরি।
রাইটার কে স্যার এটা?
হ্যাঁ,
রাইটার কে স্যার এটা?
রাইটার হচ্ছে লিসা স্যান্ডার্স, একজন এমডি, লিসা স্যান্ডার্স ইন এমডি। এটাই যে ইকেজি পেশেন্ট, ইকেজি আমরা এমবিবিএস পরীক্ষার সময় ইকেজি দিয়ে একরকম, ইন দ্য রিয়েল লাইফে ইকেজি জাস্ট দ্য বিগিনিং অফ দিস স্টোরি।
জি স্যার, স্যালুট স্যার চৌধুরী আহসান স্যারকে, আমাদের 10 লাখ ডোজ অ্যাস্ট্রাজেনিকা টিকা দেওয়ার জন্য আপনি এবং
thank you Hafiz bhai, really
we don't know yet, it's the promise sometimes can be broken, so I'm keeping a low profile and I don't like the propaganda. Let's see what happens. Work in progress.
Hopefully in our country, also in Nepal, we'll have better situation in future. And Arun, we really missed mixing together and taking exams and coming to the conferences, everything.
Actually, তোমাকে বলি ওয়াদুদ, আজকে সকালে রিপোর্ট করছে ওয়াল স্ট্রিট জার্নালে যে এন্ড অফ জুন জনসন এন্ড জনসনের প্রায় মিলিয়নস অফ ডোজেস অফ ভ্যাকসিনস উইল বি এক্সপায়ার। সো আমি সকালবেলায় ওইটা ফটো মানে ফরওয়ার্ড করছি আমি যাদেরকে চিনি, যে বাট দিস ইজ রিডিকুলাস, যে আমরা এখানে এইগুলো ওয়েস্ট করতেছি আর ওয়ার্ল্ডে millions of people dying. It doesn't make any sense.
This is very wrong. We really
Yeah.
need it.
I mean, Johnson and Johnson এর কিছু সাইড এফেক্টস আছে, ইউ জানো যে ওই যে প্লেটলেট ফ্যাক্টর 4 রিলেটেড thromboembolism, but this is very rare.
Very rare. Around 2 in million.
Risk and benefit.
Similar DIC-like complication also reported with AstraZeneca.
Jamil bhai, this is like a really, I mean, of course it is a concern.
2 to 5 per 2 million.
Yeah.
This is the incidence with AstraZeneca.
Exactly.
So it's very rare. We should not count it.
আর আমরা তো রাজি আছি, আমরা বাংলাদেশে নিতে রাজি আছি ভাই। তোমরা তো এখানে ভ্যাকসিনই নাও না, এখানে তোমরা 30-40% লোক ভ্যাকসিনই নিচ্ছেন, কিন্তু আমরা তো নিচ্ছি। আমাদের কমপ্লায়েন্স অলমোস্ট হাউ মেনি 80-90% কমপ্লায়েন্স, মানে অ্যাকসেপ্টেন্স রেট বাংলাদেশে মনে হয় তারও বেশি।
Hopefully, in our country actually vaccination
80%, like 80%.
API schedule is so good, everybody is expected to take a vaccine and they take it, their child. So the adult person taking the COVID vaccine, we should be very likely to be able to give that to most of the population.
And
if
all
it's available.
all the study done abroad and home showing very promising protective results, and one should count those results. And even one Yahoo News, I read one there said this vaccine even working against the newer strains by stimulating the all arms of the immune system in the body, not only the antibody formation.
জামিল ভাই, আপনি যে কথাটা বললেন এটা কিন্তু খুব মারাত্মক কথা বলছেন, কারণ আপনি জামা নেটওয়ার্কে আসছে দেখেন ভাইরাস ভেক্টর ভ্যাকসিন যেগুলা সেগুলোও কিন্তু ইফেক্টিভ। আমরা ইনফেকশন রেট দেখি, আমি দেখি যে ডেথ রেট, আমি দেখি সিভিয়ার ইলনেস দেখি। ব্রেক থ্রু ইনফেকশনে সিভিয়ার ডেথ ইনফেকশন এবং ডেথ স্টিল এক্সিডিংলি লো। So it is all what any vaccine is good.
Yes.
That's the thing.
It does not
Hafiz
prevent
bhai, it's
infection,
getting
but
late
it gives,
and it's already
prevents
11:13
complication.
here.
Right.
And Vascular Pharma and Review, they are actually working so hard to keep company with us. We have to thank our audience, the faculties, and also Vascular Pharma for being with us for all this year time. And hopefully in next week we'll get a lecture either from Prof. Atahar bhai or someone else, if it is possible. And hopefully we all pray that Prof. Atahar bhai's mother get well. She's actually fighting for her life. She's more than 80 years old and having COVID, and she's in ICU actually in Evercare hospital. Let's all together pray for her, and let's all pray for each other so that we again meet together in good health. Thank you everybody, and good night.
Thank you.
Good night.
Assalamu alaikum. Good night.
Thank you, sir. Good night, sir.